Podcasting from the base of Lake Tahoe in the eastern Sierras comes the Medicine Wheel. We are a group of progressive physicians seeking solutions and enlightenment while surfing the seas of big data and summiting mountains of research in an effort to make the practice of medicine more personal and medical knowledge more accessible. Our open-minded approach and inquisitive nature will hopefully shed light on new and novel concepts in medicine and empower you, the listener, to be as healthy as possible. We welcome you to sit back and join us around the wheel as we review recent news in medicine and science, explore interesting topics, discuss human interest stories, interview physicians, scientists, philosophers, shamans, and other wise folks in order to satisfy our curious appetites. Now, the Medicine Wheel.
Hello everybody, welcome back to the Medicine Wheel. We are privileged today to have a friend and a colleague of mine. Her name is Taylor Tremayne, and she's an alcohol and drug counselor who works here locally. She's come in to share some of her wisdom, insights, and advice about the mounting problem of substance abuse and addiction disorders and how she as a counselor deals with those. I'm very excited to welcome her, and I'd like to say thank you again for coming by this evening.
Well, thank you for having me. I'm excited to be here.
Absolutely. It's a pleasure. I know that you're very young in this field, and maybe you can kind of talk to us about how you actually ended up as a drug and alcohol counselor. It's certainly a unique profession, a very noble one, and something that we're desperately in need of having more of. Talk to us about what that path looked like for you.
So that path was actually kind of funny. I accidentally took a substance use and addiction treatment counseling class. In school, I thought it was an elective credit, ended up not counting for that elective credit, but I needed to minor, so I decided to take that minor. And through that, I was able to create good relationships with some mentors and some professionals in the field, and I fell in love with the counseling and wanted to pursue it. So here I am about 3 years later after my minor, and I've been practicing for 2 years. Providing counseling.
Can you talk to me a little bit about the kind of cases you're dealing with and the type of clientele you care for?
So my clientele is, I'm strictly with substance use counseling clients right now. I also provide case management, but the rural population is completely underserved. When we have clients who are needing a higher level of care or a different resource, it's very hard to get them referred somewhere. Transportation is a major issue. They have very limited, and there's actually almost no public transportation to get them to cities or places where there are the resources that are needed, and a lot of times they're on wait lists because of the need in the state.
Wow. I mean, that's such a travesty. I think that a lot of our listeners and viewers are probably privileged if they're, accessing a podcast to have transportation, to have access to, whether it be public transport or private transport, to get back and forth to doctor's offices, to counseling visits. What a shame that, because of a transportation issue, they can't access the kind of care they need. Is there anything you guys are doing to sort of circumvent that issue?
Yes, so we not only provide mental health and substance use care, we provide child care before and after school programs. We have a medical clinic. They're their own agency, but they come up and use our building to provide medical care. We have home visiting services. We work with the senior centers. We try to address as many needs as possible. When we can, because we are a nonprofit, we're limited in funds, but when we can, we try our best to help with the transportation issue, whether it be providing cash or money to be able to get a cab or transportation down. We work with the sheriff's office and the fire departments as well to try to get people where they need to go.
So on your average day when you're out in these rural areas, kind of talk to me about the sort of the age ranges and then the sort of diagnoses that you're dealing with these folks.
So with my clients specifically, I'm seeing actually teenagers all the way to elders. I have experience with all age ranges that no one normally under the age of 13 I haven't really served. I work with juvenile probation also, so I can provide services to kiddos that are coming through there. And then I've also worked closely with the courts, so sometimes I get a lot of court-mandated clients. Those are more my adults and older individuals who may have gotten in trouble or are being asked to have an evaluation or counseling done for some other reason.
So for these folks who are kind of mandated to see you, it's kind of like, they've got to establish a relationship with you kind of or else. Mm-hmm. Tell me about how that is compared to your clients who are kind of under their own autonomy coming to see you. They're not pressured into it, but are trying to get help themselves.
It's definitely a challenge when it's a mandated client. They often don't want to be there, and I acknowledge that. That's something that I put into our first encounters. Like, I know you don't want to be here, so how can we make this something that doesn't feel so punitive? Because I'm not a punitive measure. I can't force them to stay. I can't force them to come. So I really try to focus on how can we make this something that you want to do or can benefit from, rather than you have to be here and I'm just going to kind of put all this stuff that you have to do in front of you. Let's collaborate and make this something that you're going to benefit from.
Okay, well, that's a nice way to turn it around so they can use it and look at it as a positive experience versus punishment. I think a lot of folks who are been incarcerated or challenged in this way view anything that's mandated as some form of punishment. So that's a lot of wisdom that you share there and how you can turn that story around so they can be empowered by it. Let's talk a little bit about some of these younger clients. I mean, you say 13, 14, 15 years old. I mean, when I was in junior high, I would see people using marijuana and some alcohol, but not to the extent that I hear about these days, where it's just pervasive, like gross alcoholism and gross substance abuse that's even life-threatening. Can you talk a little bit about some of those cases?
Yes. So cannabis and alcohol, from my experience, are two of the major ones I'm seeing with the younger population in the rural Nevada. A lot of when I'm conversating and working with these kids is that they're saying, oh, there's nothing to do. There's nothing to keep my time. There's nothing that's engaging. And so they're going and using substances rather than providing their time to something else. Sometimes it's a family-learned dynamic. They're seeing their families or they're engaging with it with their families, and then it moves from that to doing it on their own or doing it with their friends. And it's becoming a major issue, and they're getting in trouble for it. A lot of them have been at school, caught with something that they shouldn't have at school, or a situation of that nature.
Yeah, you bring up something really important, is introduction. How do these children get introduced? In your opinion, do you think it's through the parents, family members, or is it through their peer groups at school?
For me, it's hard to say on that one. I think there's components to both. It's very interesting, the kids I work with. I've heard from family, I've seen my parents do it all the time, and I've gotten it from them, or I was out with my friends and my parents don't know that I'm doing this. So it's a give or take, I would say. I can't distinctly say one or the more than the other.
Sure. Do you ever find yourself dealing with a parent-child client situation where you actually will counsel both the parent and then separately their child?
Not in my situation. I have the scope to be able to do some of that. The parent is involved, especially if the child is a minor. They have the right to be involved in any information, but I'm not normally counseling them together or separately at the same time. I would refer one of them over to another provider, most likely.
Gotcha. Okay. Now, I know that you put together a short PowerPoint that we're going to kind of go through to help the listener and the viewer understand kind of what you do and how what you do may be something that may be appropriate for them or a family member or loved one who's suffering or struggling with addiction or some sort of substance abuse that could be harmful. So if you don't mind, why don't you go ahead and take a look at the PowerPoint, and we're going to refer to this and we'll show this up on our screen. Basically, it's simply titled Understanding Substance Use and or Abuse. Let's talk a little bit about how you make diagnoses or how those diagnoses are come to, and then when you get those clients, what do you do in and around those diagnoses?
All right. So I operate out of the DSM-5. That's the newest version of the Diagnostic Statistics Manual. And when I'm regarding diagnosis is when I'm engaging with a client and doing an evaluation, I'm looking at how their substance use is impacting their life. Is it impacting their ability to work? Are they not getting to work because they're hungover or still experiencing effects from the substance use? Are they craving the substance use or substance? Are they trying to cut down but are unable to on their own? I'm looking at if they're putting themselves in physically hazardous situations, whether that's driving or even just are they regularly getting in fights when they're using whatever substance it is. I'm looking at withdrawal and tolerance, if they're needing more or the same amount that they've regularly used is no longer doing it for them. And basing off of 11 criteria that the DSM sets out, there is now mild, moderate, or severe use of a substance. So based on how many criteria they meet will be determined of where they fall on that scale. And then for treatment, you actually refer to something else called the ASAM, which comes after the DSM. So when DSM is what I'm working at for diagnosis, and then I'm looking at the ASAM to figure out level of care for the individual.
Okay, so it's sort of a diagnostic as well as a treatment sort of manuals.
Yes, they're two different. Yep, they're both, okay. And they're kind of there to be your guidelines of how to get individuals in the right place that they need to be. And I wanted to touch on something important in the DSM that's come about is this client-centered language that they use now. Mm-hmm. It's no longer addiction or dependence, it's substance use disorder, and then the mild, moderate, or severe to put the person in control, saying instead of right. I'm an alcoholic, saying Dave is an individual with an alcohol use disorder.
Right. Now, I understand the vocabulary around this can be sensitive for some folks. Mm-hmm. And I know, early in my training, I know a lot of my patients and folks I cared for, there was a lot of shame around diagnosis of alcoholism or drug addiction. And you're saying now that there's been a paradigm shift in how we use that vocabulary to not necessarily label, but to describe it in a softer fashion. Do you think that's made an impact? I know you're new to the field, but have you seen or heard from other practitioners anything that would suggest that that change in vocabulary has helped in this process?
I would say yes. It's more of an empowering thing for clients rather than having to say, I'm an addict or I'm an alcoholic. They're feeling more comfortable as saying, like, this is just an issue I have. It doesn't have to define me. It doesn't have to be an end-all be-all. Right. It's something that I can work with and that I can work on and continue to grow from.
Great. When you look at diagnoses that are associated with these substance use disorders, sometimes they're affiliated or associated or come concomitantly with mental illness. How often do you see a patient come in with, let's say, a history of alcohol abuse disorder, that they would also have some other underlying medical condition or mental illness?
I would say very often. They are not mutually exclusive. It's very rare that they are. More so on the substance use side, it's very often that they have a mental health diagnosis or disorder. I cannot diagnose that nor treat that, but if they come in and they say, I've professionally been diagnosed with something else, my recommendation would be that they get treatment that encompasses both. And whether that's through one provider providing treatment for both, or if they're seeing me and then maybe they've got a psychiatrist that they're also seeing, and then I would have a release of information signed by that client to be able to coordinate with the other professional that they're seeing to make sure that care is being given without stepping on the other professional's toes and making sure that they're getting an encompassing care.
Great. So this sort of collaboration obviously is encouraged on all levels
right.
of medical care. So it's good to hear. I want to move on to this next slide and talk a little bit about these treatment levels. And you talked about this ASAM, or American Society of Addiction Medicine, allows you some guidance in how you take steps for the treatment purpose.
Right.
So talk to me a little bit about that, how that works.
So how this works is there's different levels, as you can see. Level 1 is probably the most common, is outpatient. That's your 1 hour a week group or individual counseling, psychotherapy, talk therapy, and then you go up from there. So 2.1 is intensive outpatient. That normally includes 9 hours of counseling or work being done by the individual within a week. Mm-hmm. And then you go up from there, partial hospitalization. You're getting partial services during the day. You're not staying overnight or having to be there all the time. And then from 3.1 to 4, oftentimes I think get clumped together as residential treatment, but there are different levels within that. So that's why I thought it important to put that in there. But they are where you are staying at a facility. Some are low intensity, so they're not as encompassing, or they're not all the time staff or something of that nature. And then you have your medically managed, where you're 24 hours medical care. Everybody's kind of around and always there for any emergencies or anything of that nature.
Yeah. So your role mainly is in this early intervention outpatient setting primarily?
Primarily, yes.
Okay. And when patients or clients, they come to see you, this is on a regular schedule, and during these sessions you guys are involved in basically talk therapy, cognitive behavioral therapy. Kind of describe to me what happens within that treatment session.
Within the treatment session, it is talk therapy. Different techniques will be used. I use a lot of motivational interviewing. That's kind of my groundwork for what I'm doing. Is I'm there to be a reflection and a mirror for the individual. I'm there to help them get where they want to be. I'm not there to determine where they need to be or tell them how to live their life or what they should be doing. I'm there to reflect where they want to get and how we can get there, and how maybe their past patterns or substance use have impacted them not getting to where they want to be, and how we can change that and motivate them to get there.
Yeah, and these sessions, they last, what, about an hour or so? Or?
Yep,
Okay.
An hour, and they're normally a weekly basis.
Okay.
That's how.
And what do you see your success rate like? I understand there's a lot of recidivism. A lot of people fail, whatever it be, counseling or medical intervention or a combination of the two. What do you see the biggest stumbling block for folks who end up sort of falling off the wagon again?
It's hard to definitively say, but I think a lot of the work I do revolves around coping skills, and a lot of people can go out and be in recovery or sobriety for many years, and then a major life event happens, and sometimes they just fall back into those patterns because it's something that makes them feel good, and it's something that reminds them of, like, oh, I don't have to worry about it. I can escape this situation in a sense. I don't know as of numbers or anything, but I would say that's probably a big one that leads to relapse or not being able to keep their sobriety for length of time. And sometimes you hear a lot about the rock bottom. People have to hit that. It's sometimes true. People need, they've done multiple treatment centers. They've done multiple counseling sessions. They've done all kinds of stuff, and they still continue to use. And there's a level of motivation that people have to have, but also an understanding that the brain has changed when you're using substance. The brain is a chemical lab, basically, and so you're introducing these substances, and it has an effect. So there's a lot to encompass in how you approach it.
Well, you bring up something very interesting, and that's the concept of sort of trauma knocking people off of their sobriety pathway, and that comes in many shapes and sizes. What do you think is the most common trauma that you hear about that causes somebody to sort of go back into using?
From my experience, one of the biggest traumas that either initiates use or gets someone to break their sobriety and relapse would be a death of a loved one. That's, just from my experience, the most common one I've heard. Parents dying or siblings dying, close friends. That's been a major one that I've seen in my experience. As far as a whole or on a bigger level, I'm not sure. I think it could be different for everybody.
Right, different thresholds.
Mm-hmm.
No, that's it's very interesting. Let's go on to this third slide here and talk about the dimensions on the ASAM.
Yes, so these dimensions are how I determine that level of care of what we were just talking about. So there's 6 of them, and when I'm doing this evaluation, I'm looking for diagnoses, and then I'm also looking for kind of the support systems and things they've got in place. So I'm looking at whether they're withdrawal potential, do they have potential to withdrawal, or have they been the biomedical conditions and complications. Are they reporting any diagnosed by professional biomedical conditions? Scoliosis, cancer, those kinds of things. And I'm seeing if they do have that, how their substance use interacts with that, or substance use interacts with that. Same with the emotional, behavioral, and cognitive. Do they have any previous mental health diagnoses? If yes, how is their substance use interacting with those? Readiness to change. we're looking at these stages of change and where someone falls, pre-contemplation, action, all of those kinds of ideas. So does someone want to change? Are they expressing motivation and preparation to go and do the change? Are they still thinking, I'm not really sure if this is a problem? Right. And then I'm assessing that. Relapse and continued use, I'm looking at their history. Do they have a extensive history of substance use or a small history of substance use? What is the potential for them to continue use? And then the recovering and living environment. Do they have people around them who support sobriety, who support them getting help, or are they going back to a home where they're going to be using, people are going to be using around them, or trying to get them to use and not providing a support system?
Yeah. Well, this is an amazing list. The way you sort of talked us through it is really reminds me of the show Intervention on I think it's A&E. It's on cable TV. So, when I visually went through my head these cases that I've seen on the show where there's some that just sit down and they're like, it's time. Yeah, I have to do this or I may die. And there's others who are like running out to their addicted, significant other's van and jumping in the van and driving away. And all this sort of resonates when you see these stories of these poor folks unfold. What do you see as some of the signs that your client is going to be on a good track? I mean, what do you look for in those sessions?
Readiness to change is a really big one for me, is seeing what they're saying. Some people will be like, I don't have it. I don't abuse it. I just do it for fun, this and that, da, da, da. I have no issues from it. It doesn't impact my life negatively at all. And then I have others who say, I lost my kids due to this. I need to get my kids back. I want to be a good parent. I want to have a good life and be on track and be a good person. Not that people who are using substance aren't good people. It's just their motivations are different. And so I'm really looking at what they want and what they're expressing to me, because that's going to be my idea of where they want to go forward, or if they want to go forward at all.
Yeah. One thing that sat very curiously with me is the families of these addicted or I would say substance abusing folks on the show were like, no matter what their background, they were all coming together to try to help this one individual. And many times it would be 5, 6, 8 people there, plus the mediator, the counselor. And even then, in the face of all this outpouring of love and support, they could actually thumb their nose at that and go, you know what, meth, heroin, alcohol, whatever, something else meant so much more to me than this love and connection with their intimate community, that they would leave that. So what that tells me is that the level of, I would hate to say it, mind fuckery that goes on with these substances is beyond the pale. And how do you overcome that in so many circumstances when that's the choice that they've made over and over and over again, and that's how they self-satisfy? It seems like your job at times must be incredibly difficult.
It is. And there's one of the last slides in this presentation that we'll get to, kind of where you're coming from, is this moral model idea of addiction, is that it's a choice and they choose, and they're choosing it over their family, they're choosing it over their kids, they're choosing it over and over and over. There is a level of choice, but there's also other factors that can be compiled into it. And so as a provider, I think it's important that we assess that and we see where we're standing from. So I like to come from more of a biopsychosocial idea of, I want to encompass all. I want to encompass your biology. I want to encompass your environment, your raising, and all of that, and not just your moral choice, and encompass who you are as a person, what led you here, why are you continuing to use, what is your fear of stopping use, and all of that, so that I can determine, and why you would choose to go use rather than go to a treatment or anything like that. Right. And it also can be overwhelming. I mean, even for someone who's not using substances, to walk into a room of 8 people who all love you and pouring out that love and pouring out that support can even be overwhelming for someone not on substances. So when you're stimulated, that could be even more
a reason to run.
Right.
Yeah. No, that's excellent. Well, let's go on to this next slide and take a look here. You talk about comorbidities, and this gives us a little idea of how brutal this problem is.
Right.
So let's talk about some of these statistics.
Yes. So the most recent stats I could find are from 2016. So of 19 million adults who had a diagnosable substance use disorder in the past year, 8.2 million had a co-occurring mental health disorder, any mental health. So that's about 43.3%. And then of that 19 million with the substance use disorder, 2.6 had a serious mental illness. So that's about 13.8%. And this lines up with some other research I found, which says about give or take 50% of people who are being seen for substance use are going to have a mental health diagnosis, which I agree with from my experience that they are.
So this is sort of an at-risk community. They're going to be prone to having, and whether it be self-medication or self-soothing or whatever they're trying to do to treat themselves, they're kind of at risk in general.
Yes.
Okay. All right, let's go on to this one. So these are types of treatment, and obviously these are some medical ones. Can you talk a bit about them?
Yes. So medicated assisted treatment, or MAT, is what you'll hear it as a acronym. This is where you hear about like your methadone, your naltrexone, Suboxone used to be a one, but I never can get that right. Buprenorphine. This is where people are going to prescribe or to medical professionals and getting prescriptions or going to a methadone clinic. And MAT treatment has high success rates when in conjunction with talk therapy. They have the best recidivism.
Yeah, the more chance to stay on the wagon.
Yes. They have a better rate through medicated assisted treatment, being that it helps with the withdrawal symptoms, because a lot of times when you're seeing people using heroin or meth or things like that, even they will say that I want to stop, but when they start hitting those withdrawal symptoms, they are so nasty and ugly that they can't take it and they want to continue to use because they want to avoid those withdrawal symptoms even when they don't want to use. So MAT is great for that, to help someone slowly get off and to provide the talk therapy and the medicated assisted treatment to alleviate some of those symptoms. Now, that doesn't come without controversy. A lot of people don't agree with MAT treatment because it is medication. They say, you're filling one addiction with another. And how do you curve that? How do you work with that? So there are controversies against it. It does have success. It also has that. And especially when you see like your AA communities and your NA communities, they are a good one against MAT treatment because they want you to be sober from everything.
Yeah, and I'll be honest, I've sort of straddled the fence on this, because I have seen exactly what you describe, is that by taking away that safety net of avoiding, the potential pitfalls of physical withdrawal, you really expose these clients to like really horrendous potential physical side effects from coming off specifically heroin, and that is something that I think nobody looks forward to. And I've been in situations, working in the rurals and then even at Burning Man, where patients would be in acute withdrawals, and we don't have the resources that they need in the middle of the desert at a festival, while they've got a bucket they're sitting on and shitting their brains out and they're puking the other one. You don't want to see anybody go through that, and let alone for a long, prolonged period of time where they're trying to clear their system and recover. So I agree that definitely medications do play a role, but then on the flip side, I can say that certainly some of the most successful folks that have kept clean have been actively involved in NA and AA. So I can see both sides, and I think I basically just handle it with each individual and treat them in this holistic way that you describe, which is probably the wisest thing. So take each case as it comes.
And that's part of why I love my job, is because there is no black and white. I can't have you walk in and be like, here's 6 things, take this, you'll live a happy life and live forever. It is a relationship. It's a different kind, definitely an odd relationship when you're creating that therapeutic relationship, but it's so great because you are listening to this individual. You're providing them with something that they want and that they don't normally get. It's not often that we are going throughout our day and throughout our lives and people are like, what do you want? How can I help you get there? What is the true you? Give me the rawest you can be, and I'm here to listen and not judge you.
Yeah. And that's excellent. And, since I've known you, that's something that I really picked up on, was there's a level of presence and wisdom that is beyond your years. So I always appreciate that. And I know it was one of the first things I mentioned to you when we met. But let's keep going on. I know our listeners are excited to see what's coming up here.
So and then there's talk therapy.
These are more types of treatment.
Yeah, okay. So your talk therapy, I just wanted to touch a little bit on the licensure limitations like I talked about before. Being substance abuse treatment counselor, I cannot diagnose nor treat the comorbidity. So it is a little bit of a tricky situation there, especially if you know someone has a previous diagnosis and is getting the mental health treatment somewhere else. That coordination of care is going to be super important, and just making sure that you're not overstepping your bounds or overstepping your scope of providing the treatment. So that's also an interesting thing, but just something to be aware of when you're working with individuals under just the license of a substance use counselor, that you're not overstepping your limits.
Sure, and that's very wise.
Yes.
And you talk about successes down here. I know there's multiple modalities and multiple levels of therapy, but personally, what have you seen through these therapeutic relationships as sort of positive success stories? Anything that stands out for you?
I've had a couple who really have warmed my heart, and I've seen walk out very happy, which makes me feel good that I've been able to help them. Some of my favorite successes for me have been my clients. I had a client who was mandated, who came in and was like, "How are you going to help me? I'm only here because I have to be." And 3 months in, I had him crying in my office, talking about the real stuff and talking about what's going on. And then when it came that his mandated treatment was completed and he had successfully met his treatment goals, he asked to continue. And I count that as a success. And I've had a couple of clients like that. And that's what I would count as a success for me, is that, they found benefit in it and wanted to continue until they felt that they were ready to go. Because counseling is not meant to be every week for the rest of your life. We're there to help people be self-sufficient. We want them to go off on their own, but we want to be there for them until they're ready to do that. So
That's wonderful to hear. Let's go on here to the models of addiction. I know we just touched on some of this earlier, but can you go into a little more in-depth about this?
Yes. So your moral model is the one we were talking about, where it's, you're choosing this, you're doing this, it's all an option,
Shame on you.
Pretty much,
Yeah.
It's that, drugs are bad, don't do it kind of mentality. A lot of law enforcement kind of comes from this idea of moral model. Disease model is where you see, like, this is a disease I have, it's a medical condition, I have no control over it. Sociocultural, where your background is, your environment, your raising. Psychological model, your predisposition to it, or any other mental health diagnoses or anything of that nature. And then you have the biopsychosocial, which kind of puts them all together, smashes them, and wants to look at the whole person, the whole outlet.
And it sounds like that's kind of the model you prefer.
Yes. For me as a provider on a personal level, yes. I like to look at all of it. What's going on with you as a whole for you.
Great. Now let's talk a little bit about your sort of day in and day out processes. I mean, I know it's not necessarily your traditional, you sit down, see one patient, and then you do the next. I mean, what administrative roles do you play? I mean, do you help coordinate care? It sounds like you're doing a little bit of social work as well.
Yes. So counseling does not come without case management. You have clients who have other needs, and those needs are important in the counseling setting. They're not being able to meet certain bills or this, or housing is oftentimes something we see along with transportation. So you're also providing those case management of, like, okay, let's try to find some resources for you on that level as well. Where can we get these other things that you're needing? And you have your notes that you're writing for each client, and you're having these releases of information, which I mentioned before. Permission from your client to talk with other people. So whether it's another care provider, their doctor, their lawyer, their court judge, anything of that nature, anybody that they want you to share information with. Even if I were seeing, say, like a 24-year-old individual, and he wanted me to be able to express with his mom what was going on, I would have to have a release of information, or else I wouldn't be able to share whether or not he was even a client of mine, even if she were to know.
Right.
So there is a lot of background legwork that goes into it that clients don't see themselves. And as a whole, I don't think people understand about counseling is there is a lot of background legwork that you're doing. It's not just, okay, client, all right, have a good day, and then I'm done.
Right.
I'm doing research for them. I'm reaching out to their other providers or individuals that they would like me to, and sharing information so that we can get them back on their feet and moving towards where they want to go.
Great. Well, there's one thing here, at least in the Northern Nevada, Northern California area, that we've seen a lot of, and that's homelessness. And I know that there's a strong correlation between substance abuse, mental illness, and ultimately being sort of disenfranchised from society by losing your home, vehicle, a safe place to, find shelter. Can you talk to me about what your clients kind of deal with on that level? Because you kind of alluded to it earlier.
Yeah, we have clients who deal with all of those. It is hard as a provider because there are certain limitations and boundaries that are set that I can't give them rides places. Right. I can't do those. And especially being a nonprofit and the situation of the area we're in, I mean, all of the homeless shelters are full and they're over full. And it's really difficult right now to address some of those needs. And that's very difficult as a provider to be providing treatment when some of these basic needs aren't being met, because at that point, it's going to be hard for the treatment to stick, because it's just like that illusion of or the analogy of school kids, when they're hungry and they're not being fed and they're going to school and trying to learn, they're not going to retain anything. It's the same goes for treatment.
Yeah. Yeah, if your basic needs aren't even met, I mean, last thing I'm going to be worried about is, I got to give up the booze. In fact, the booze may be the only thing that I cling on to.
Right.
Yeah.
And so, it's very tricky, and because I want to see people do well, and that's why I'm in the position I'm in, and I do the work that I do. And it's really frustrating and difficult as a provider on a treatment level, because I know these basic needs aren't being met, but then also on a case management level of I don't have resources to be able to get these basic needs met in the first place.
Right.
So it is definitely something that clients have experienced, or when they first started treatment, they were fine, and then all of a sudden now they're homeless or something of that nature.
Yeah, they're in the process of hitting rock bottom as you encounter them. Yeah.
Right.
Well, you know what? I have been thrilled to have you here, and it's been awesome listening to not only your background, but a little bit about the story of what you do and some of the tools you use. I want to know if you can share any pearls for our watchers, listeners, viewers, in and around, whether it's a family member or even themselves. What are the key decisions? What are the key things that they need to do in an effort to get the kind of help that you provide, or that a social worker might provide, or a psychiatrist or psychologist might provide? I know you can speak locally, but in general, throughout at least the United States, where might people go to get that kind of help, just to start that ball rolling? They just pulled the needle out of their arm and they're just like, well, when I wake up, I got to stop doing this. Mm-hmm. What do I do?
It's hard to say. Hospitals, they could probably give you some good resources of where to go. Any mental health place, you also have your suicide hotlines, and they now have substance use hotlines and things of that nature, so that you can call a 800 number and they can find you resources wherever you're at. And I really say that if you as an individual are thinking about that maybe your substance use is starting to be an issue, that you go and explore options. And as a family member, to not be pushy, to not overbear someone, because ultimately they've got to choose to do what they're going to do. Yeah. And so, I just encourage people to treat everyone like a human. Everyone is human, even if they're using substances or not. We've all made mistakes. We've all done things that we're not proud of. And so it's not fair to shame or put the stigma, and help alleviate that and empower the individual to do what they want to do. Or if it's yourself, to empower yourself to go forward with your goals.
Well, simply with folks like you out there, I am going to say that these issues that many of those folks face are going to be able to have solutions found for them. I've been very impressed by the information you shared today. So thank you again for doing that. This is Dr. Sean Devlin, and this is the Medicine Wheel. We'll invite you to listen to us on a regular basis. And I just want to say thank you, Taylor. It was awesome.
Thank you for having me.
You bet. Blessings.
The Medicine Wheel encourages all of our listeners to subscribe to our newsletter and podcasts as we continue to explore the world of medicine, bringing you up-to-date health and science information. The Medicine Wheel invites our listeners to email us any newsworthy stories or topics they wish to explore further and discuss on the podcast. For more information about the Medicine Wheel, please visit us at our website, www.themedicinewheel.org, and on Facebook at The Medicine Wheel Podcast, and finally on Twitter and Instagram at The Med Wheel.
In an effort to support access to integrative medicine and functional medicine options for those in need and education for those who need information, please consider donating to Project OmCare, 501c3.org. Please go to our website, www.themedicinewheel.org, to learn more.
Thank you again to all our local sponsors, Grateful Gardens, Lighthouse Coffee, and Dorinda's Chocolates, which represent some of the best organic and appetizing options in the Reno, Tahoe area.
Lighthouse Coffee Shop is a proud sponsor of the Medicine Wheel. We are a family-owned and operated local coffee shop. Our goal as a business and a family is to cultivate community wherever we are. All of our coffee is ethically sourced, organic, and farm fresh. It's roasted in-house daily, guaranteeing you access to the freshest cup of coffee on the planet. We care deeply for our community and everyone in it. We strive to provide you with the best ingredients and most comfortable environment. Come and enjoy coffee with us. We are family, and we would love for you to be part of it.
Gerber Medical Clinic is proud to support the Medicine Wheel and medical education to improve health quality, nurturing the lifestyles of our listening community, enhancing wellness for all. Thanks again to Wired Insights and their talented team for making our podcasting dream possible.
In closing, we would like to remind all of our listeners, if you have a medical concern or diagnosis, you need to see your personal doctor without delay, and if needed, obtain a referral to a specialist. If ever you feel the health issue you have is urgent or an emergency, please call 911 and go to your nearest emergency room. Please do not take any of our physicians' commentary or our guests' opinion as medical advice, and always seek out medical care from fully licensed and appropriately trained medical professionals in your area. The information shared in this podcast is for general information only and should not be construed as medical advice, and understand that no doctor-patient relationship is formed. The use of this information and educational materials linked to this podcast and website are employed at the user's own risk. The content of this podcast is not meant to be used as a substitute for medical advice, diagnosis, or treatment.
This is the Medicine Wheel signing off for this week with a reminder to live, love, listen, and learn.